Hello, everyone. This is Dr. Job Mogire from the House of Mastery with the EKG Mastery here. And this is going to be our first session. And the goal of this session is to cover some of the foundations, the crucial foundations that we need to build a stable basis upon which to interpret EKGs. What we are about to cover, if you grasp it really well, the next time you look at an EKG, you'll be thinking about it very differently. And I hope that by clarifying these basic principles, the next couple of steps that we will take, especially when we practice some EKGs, will become so much easier and more fruitful. So we start off with this grid that I was beginning to draw. You have this x-axis, but you extend it to both the negative and positive side. But this, instead of being x and y, it is lead 1 and lead AVF. That is augmented vector F, where F represents foot. And because it's going this way, where it is starting from is negative, and where it's going to is positive. That is the same thing with AVF. Where it's going to is positive, wherever it's coming from is negative. The heart in the chest, if this was the chest, the heart, this is the chest, and somewhere over here is the midline. The heart does not lie straight in the chest. It does not lie straight like this. The heart lies to the side. It's almost diagonal. And therefore, when there is electrical activation at the level of the atria, especially the right atrium over this side, maybe around here, and travels down to the atrioventricular node and then goes down to the ventricles, the overall vector, neutral vector of the heart goes down this way. So the overall vector will be somewhere in here. And that is the summation of all the electrical currents, such that the overall direction, regardless of what regions of the heart are being activated, the overall vector will go this way. And it's important for you to pay attention to that, the orientation of the heart in the chest, because when we talk about left axis deviation, meaning the heart, the apex of the heart has turned this way, or the electrical forces have turned that way, or you talk about right axis deviation where it turns this way, that is what you are relying on. You are relying on portraying the deviation from the neutral, the expected neutral trajectory of electrical activation, and figuring out, is it going right axis or left axis? So the important foundations to pay attention to here is that the heart has an overall electrical trajectory of all its signals, and that is what this projects over here. That we can then measure, figure out whether there is any enlargement of any of the chambers, or there is bundle branch blocks that have changed the direction of electrical current flowing, so that when we see any of either right axis deviation or left axis deviation, we are seeing information that we need to act on. But before we get there, this is the foundation. So you need to pay attention to this first two leads, lead 1 and lead AVF. Now, lead 1 this is a vector. Because it's a vector, it's in this position. It means it can be drawn at this level, it can be drawn down here, it can be drawn up here, which is why lead 1 most of the time is actually drawn up here, like that, going from right to left. And then lead 2 is generally drawn close to where the neutral vector is. So if we would draw lead 2 somewhere in here, maybe we can just draw it here. That is lead 2. So this is lead 1, this is lead 2, and lead 3 is usually drawn somewhere here. And you will soon see why this is extremely important to pay attention to. So just as lead 1 can be drawn at this point or drawn at the top, because it's a vector, it can be at any position. What matters is the direction. The same way lead 2 is over here, but lead 2 can be drawn anywhere. along this trajectory, which is why lead 2 is often drawn this way. This is lead 2, so that what you draw here will actually be parallel to lead 2. So this is lead 1, this is lead 2, and lead 3 is over here, which means you can draw it anywhere as long as it's parallel to the vector, because it doesn't have a geographic location. It is a vector. It just follows a direction. And so lead 3 is often drawn like that, coming from up there, coming this way. Lead 2, positive this side. I mean, negative this side, sorry, negative and positive down here, where it's going to. Same thing. So lead 3, this is lead 3, this is lead 2, and AVF, they are all positive facing inferiorly. And that is an important point to pay attention to. So we need to add a couple more leads. So remember, this is lead 3 here, this is lead 2, and when we draw them from this point, we just portray them as if they're starting at the center, just so that we don't have it cut across. And the two leads that are missing that we need to add here now is lead AVL, augmented vector left, and AVR, augmented vector R. And so what have we done up to this point? It's an important consideration to think about, because this is a crucial foundation of electrocardiography. So the main thing to pay attention to, the first question rather to answer, is where are these leads operating? We have all these leads here. We have lead 1, we have lead 1 up here, lead 2, lead 3. Lead 1 over here, lead 2, lead 3. And we then have lead AVL, AVF, and AVR, which makes them a group of 3, 2 groups of 3, 3. And so the AVR, AVL, and AVF are one group, and the other are the 1, 2, and 3. They're 2 different groups. If we take this orange as the heart, right? And we say that the heart does not lie straight. It doesn't lie straight like this. It lies diagonally. So if you have this orange here as the heart, okay, and you have these leads operating, these leads, what is unique about all these 6 leads is that they don't look at the front part of the heart. They do not look at the anterior wall, the anterior, mostly the anterior medial or lateral wall of the heart. If you have to infer anything, it's going to be the high laterals, the high medial lateral, the high lateral, the outer lateral. But overall, just think of these as leads that cut through the heart. They go sagittally against the heart. So if I had a knife right now and I was cutting this orange like this, cutting it like this, I don't know if you can see what I'm trying to do. If I was cutting this orange like this, okay? Cut it like this, and then I lay it down, okay? Lay it down so that half is below it and the half is above. These leads cut, they are sagittal, they cut through the orange like this. They cut it in half, so they don't look at the front side of the heart. So you are using these vectors, all the 6 of them, that we'll talk about how they are combined. You are using them to look at the overall trajectory of electrical activation in the heart, and you're also using them to infer what is going on in the posterior and the inferior walls of the heart. And the reason is because the other group of leads, the other 6 leads that we use on the heart, which are V1, which would be usually on the right side, and then you cross over to the left side, V2 all the way to V6, with V4 somewhere in between, V3 here, and V5 over here. the purpose of these leads, the only thing that this leads V1 to V6 do is look at the anterior wall of the heart. The anterior and all the way to the lateral. Rather, it's the part of the heart that we can see when you're looking at the heart from the front. Everything that you can't see from the front will be looked at by the other leads. And therefore, when you look at an EKG, if you are looking at V1 to V6, you are literally making decisions regarding the overall electrical signals that are happening mostly on what you can see, mostly the anterior and anterolateral wall of the heart. And it's because we can't see anything beyond V1, V2, V3, and all the rest that these other leads were invented. So 1, 2, 3, AVL, AVR, and AVF were invented to look at the posterior wall and the inferior wall of the heart. That's one. And then number two, they help us remember the overall implication that we see when we look at them is what direction is electricity flowing, what are the vectors of activation. When we look at things like right axis deviation and left axis deviation, we are not using V1 to V6 at all. We are only using the other leads which look at the overall electrical activation, and we generally just use lead 1 and AVF, and then we'll add lead 2 when things are equivocal. I hope that this does not confuse you, that it gives you some level of clarity. So let's just do a quick review. When you are talking about lead 1, lead 2, and lead 3, okay? So this is lead 1, this is lead 2, this is lead 2, rather, this is lead 3. You are talking about these vectors from right to left, and then of course this one is coming down to the foot. You get a summation of all the three together to figure out what direction electrical activity is flowing. Because the heart does not sit straight vertically, it sits like this. And anything that is going towards the positive end is going to be positive. A lot of the times you will find that on an EKG, that's an example that I have here, if it's a normal EKG, that lead 1 is going to be either positive or almost neutral. And why does it become neutral? It becomes neutral if the electrical activity is no longer going more this way, it's going more down this way, such that this lead is seeing current going almost perpendicular, and therefore it is essentially neutral. But otherwise, lead 2 is almost always positive, which means the major orientation of the QRS axis is upwards. That's what we call positive. If it's facing down, it becomes negative. And lead 3 goes, it still faces down, but it goes a little bit to the opposite side, such that if you have left axis deviation, this and the axis of the heart goes leftward, that means you are almost beginning to go against the flow of lead 3. And therefore, lead 3 either looks positive or looks negative. So this is what you need to think about when you look at an EKG. You are thinking separately about lead 1, lead 2, lead 3, so that you don't mix it with the rest. First of all, really quickly, just getting an idea, okay, what is lead 1? Because you are looking for the overall vector. The overall vector is going to be something like this. The overall vector of the heart is going to be something like that. So if it's like this, it is heading towards the positive end of lead 1. So lead 1 will be positive. It's definitely going to the positive direction, almost parallel to lead 2. So lead 2 will be positive, and lead 3 can be positive or it can be neutral, depending on how the electrical activity is flowing. If you find that lead 3 is strongly positive, then lead 1 is either going to be small or almost neutral. For example, in this EKG example I have here, if you look at lead 3, which is this one here, it is very strongly positive. Lead 3 is going down. So that means in this heart is oriented in such a way that the overall electrical activity is more turned this way, such that it's almost beginning to become parallel with lead 3. That's why lead 3 is so positive. And once it turns like this, it means lead 1 is now beginning to see this electrical activity going down almost perpendicular, which is why in this EKG you see that lead 1 does not have it doesn't have the strongly positive deflection that we expect. In fact, it looks like the negative deflection, the downward deflection, is bigger than the positive deflection. So when you look at an EKG, lead 1, lead 2, lead 3, they get interpreted together, and you interpret them together to answer this question: what is the overall direction of electrical activity? If you see a strong deflection in 1 and 2, most likely you have a normal overall trajectory of electrical activation. But if you begin to see that 1 is either neutral or it's actually negative, it means that you have turned the heart, you have rotated the heart the opposite direction. And you think of that this way, that lead 1 is positive this side and it's negative this side. AVF is positive down here, is negative up here. So that if the heart axis is like this, you are in this quadrant where AVF and 1 are both positive. And that's what we call normal, when they are both positive. So 1 is up and they are both up, that's positive. But if there is left axis deviation, in other words, the heart deviates to the left side, so it means it essentially leaves this quadrant and goes into this quadrant. In this quadrant up here, lead 1 is positive because you are on this side of this line. Lead 1 is positive, and because you are on this side of AVF, because AVF is this one here, you are on this side, up here AVF is negative. So in left axis deviation, lead 1 remains positive, but then AVF becomes negative, such that on the EKG, there's something we call they are leaving each other, just like in WhatsApp groups when people left. So when there is left axis deviation, these two leads face opposite, such that lead 1, because lead 1 is remaining positive because you are on the positive side and AVF is negative. When you look at an actual EKG, we'll do several examples. I hope that becomes something very simple. And if there is right axis deviation, which means the heart is now rotated to the right this way. From its neutral expected natural trajectory, it rotated this way. You come into this quadrant here. In this quadrant, AVF remains positive, but lead 1 is now negative, which is why in right axis deviation, the lead 1 faces down, which is negative, and AVF faces up. And the two of them together, if you hold them as thumbs, the thumbs face each other, where 1 is going down and AVF is going up. And so these 3 leads, they help you answer the question of what is the overall trajectory of electrical activation. And we will see where to apply that information, especially in terms of figuring out whether there is significant chamber enlargement, whether it's LVH or RVH, or there's a bundle branch block, or in the setting of ischemic disease when a patient has significant infarction of some component of the conduction system, that can lead to deviations in terms of the overall trajectory of electrical activation. The final thing I wanted to mention here is that if you draw the heart, like we'll just draw the heart something like this, and we say that the heart does not sit straight, it sits diagonally with the apex down here. So this is the right side of the heart. This is the inferior wall of the heart. And of course, this is the high lateral. We don't really necessarily see the lateral wall, but this is the high lateral. And then of course, the anterior wall will be covered by this. So V1, V2, we call them septal leads. They sit right over the interventricular septum. And then the rest of them kind of overlap. So from V2 all the way to V4, we call them the anterior leads. Anterior or anteroseptal leads, because it touches a little bit on the septum. And then everything from V4 all the way to V6, we call them the anterolateral. So there are no strict boundaries. These are just regions. So the important thing to pay attention to with regards to this is that these are geographic locations. We know where they are. V1 is always in this location. V2 is always in this location. V6 is always in that location. On the placement of EKG leads, we have specific descriptions of where to place the leads, and it's just one single lead for each of these. These other ones are not single leads, they are vectors. And the vectors are created by the placement of different leads, and then the different leads create the vectors. So the other ones are not geographic locations. You see, because we can see the anterior wall of the heart, we can target it with specific geographical locations all across, from V1 here all the way V2 all the way to V6. So this is the anterior wall. Maybe if the septum is over here, this is the anteroseptal, and then you have the septal, anteroseptal, maybe up to 3, but especially from V2 all the way to V4, you call those the anterior, and then from V4, including V4, that is all the way to V6, you call that anterolateral. So the V's, they look at the anterior wall. Because we can see the anterior wall, we can give it a geographic location to look at it specifically. But the posterior wall, we cannot see. The inferior wall, we cannot see directly. That's why we need the vectoral leads. That is 1, 2, 3, and AVF, AVR, and AVL, because they are able to look at that side. So when you have inferior wall infarction, the reason why you rely on lead 2, lead 3, and AVF is because of how these vectors are oriented. These are the only 3 vectors that cut through the inferior wall: lead 2, lead 3, and AVF. V1 does not cut through the inferior wall. AVL does not cut through the inferior wall. When you have a posterior infarct, that is where you need 1 and AVL, and you end up adding additional leads beyond V6. That's when you go and put the posterior leads, the V7, V8, and V9, which go all the way to over the scapula at the back, so that then you are able to geographically look at the posterior wall, but then also you utilize 1 and AVL. That's because 1 and AVL, they look at the high lateral wall. When we have a high lateral infarct, which is in the vessel we call the OM, or the left circumflex, that is where we utilize 1 and AVL. Otherwise, 2, 3, and AVF, purely, they show us what is going on in the inferior wall. In addition, of course, we utilize them to figure out whether there is right and left axis deviation. The only lead that is remaining we haven't spoken about is AVR. The way the heart is vascularized, if this is the aortic annulus, from the aortic annulus, you have 2 main vessels come out. You have the left main artery, and you have the right coronary artery. And this is the interventricular groove. So the left main comes, and at some point it subdivides and gives you the left circumflex, which goes round along the interventricular groove and goes to the back. And from the back, it gives you a couple of branches. After giving the left circumflex, the rest of this vessel comes down at the front of the heart as the left anterior descending artery, which is the main artery of the heart at the front. On the right side, rather, the right coronary artery comes out. It doesn't give any major branches. It just goes straight into the interventricular groove and goes to the back. Now, you have 2 circumflex arteries. You have the left circumflex artery going this way, and you have the right coronary artery going this way, and they meet at the back. And then one of them at the back gives you the posterior descending artery. So you have two circumflex arteries. Circumflex just means going across along the circumference of this interventricular groove. So you have the left circumflex, LCX, and you have their RCA. They go to the back, and one of them gives a descending artery, and the two descending arteries descend all the way to the apex. One of them supplies the majority of the apex, and usually that is the LAD. When you are making interpretations with regards to what the infarction is, generally, V1 all the way to V6, generally, they tell you about what is going on with the left anterior descending artery, unless there is a much more proximal infarct that is involving a little bit of the left main and affecting the left circumflex. But otherwise, V1 to V6 will tell you mostly about the left anterior descending artery. Lead 1 and AVL will tell you about the high lateral wall, which is generally supplied by the left circumflex. Therefore, when you're looking at an infarct and wondering where might this be, that is what you are doing by you are grouping the leads to make sense of which lead is going where. The RCA comes this way and goes to the back and generally gives us the posterior descending artery, which supplies the inferior wall. When you're looking at infarction in the region of the RCA, you are looking at lead 2, lead 3, and AVF, because these are the only leads that look at the inferior wall of the heart. So the final lead we didn't look at yet is AVR. It is very different from the others because it goes in the opposite direction. All these other leads, you could draw a line here, and all these other leads, they go a little bit in this direction, but lead AVR goes the opposite direction. We utilize AVR in special situations. One of them is when there is blockage of the left main artery. It causes changes, very distinct changes in AVR. So if you see ST elevation in AVR, you have a left main STEMI. That's a big deal. That's a killer. That's bad news. But also when you have an arrhythmia such as ventricular tachycardia and you are not sure whether it's VT or maybe one of the other less benign, rather more benign arrhythmias, you check AVR, because if you see that AVR is positive and you think it's ventricular tachycardia, if it's positive, it means that electrical activity is starting somewhere down here and coming towards it. Because in electrocardiography, when things are positive, if electrical current is approaching, and negative if electrical current is going away, which is why, for example, AVF, it is negative up here, positive down here, because electrical current is going this way. So ventricular tachycardia, one of the hallmarks that we see, if AVR is positive, it means electrical activity starting somewhere in the ventricle and then rising up this way. And when we see that, that's a very strong suggestion that we are probably dealing with ventricular tachycardia. And that makes it a more concerning observation whenever we make that observation. So going back to finish off on this here, we had drawn this grid at the center like that. So these are bipolar leads. Lead 1, lead 2, lead 3. These are bipolar leads. They start from here. This is negative, go to positive side. This is negative, positive side, negative. They are bipolar. The other leads, these are the what we call the A's. They are augmented. They generally, we count them as starting at the center. They are not bipolar, they are unipolar. They are augmented. They are vectors, but they are unipolar vectors, which are supposed to help us augment what we are observing with regards to interpreting the electrical activity. Now, the final thing before I do a quick review of its application on EKG is that from today, the next time you hold an EKG, you can literally draw a line. Maybe I should use this pen here. You can draw a line and separate. So this EKG is printed where these three down here are rhythm strips. And we have, I think this is V5, this is V1, and this is lead 2. This is V1. So these are the way we print EKGs in our system. These are all rhythm strips, and you can ignore them and just can actually ignore them and just focus on the upper part. The next time you look at an EKG and you have these 6 leads, you can draw a line mentally, depending on how your EKGs are printed. You can draw a line and separate these leads into 2 groups. These are geographic locations. Where these leads are is where they always are. These are vectors. These are vectors. These vectors here, they help us get an overall picture. And then these other vectors, they add special information. This vector here looks at the region of the left main mostly, the proximal part of the anterior wall where the left main comes. This AVL looks at the high lateral wall, and AVF looks at the inferior wall. Now, when we look at EKGs, one of the most important concepts that we think about is contiguous leads, such that we define, for example, STEMI by looking at the presence of ST elevation in contiguous leads. On this side, it's very easy to figure out which are the contiguous leads. V1 and V2 are contiguous, which means they are consecutive and they are adjacent to each other, V2 and V3, V3, V4, V4, V5, V5, V6. They are contiguous leads. It becomes tricky when you look at on the other side. Over here, lead AVR stands on its own. We don't count it as being contiguous with anything else. What sometimes eludes people's attention is that lead 1 and lead AVL are contiguous leads. And why are they contiguous leads? Because they look at the high lateral wall together. So when you are looking at the EKG, you see ST elevations, you look at lead 1 and lead AVL together. So that if you see ST elevation in 1 and you also see it in lead 2, then you have already met one of the basic criterion for deciding whether you're dealing with a STEMI or not. Or even if it's not a STEMI, just any other ischemia. If you see T wave inversions or Q waves over here, and you also see Q waves over here, that means there has been an infarct in the region supplied by some part of the left circumflex. So these two are contiguous leads. And then, of course, lead 2, lead 3, and AVF are contiguous leads. These are contiguous leads for the inferior wall. These two are contiguous leads for the high lateral wall. The AVR lead stands on its own. We use it in looking for a STEMI in the setting of a left main obstruction, or in case we are concerned about ventricular tachycardia. And then, of course, on the other side, if we are worried about proximal LAD, left anterior descending artery occlusion, then we are looking mostly at these 3, V1, V2, and V3. And if it's farther down, then of course, you look at the rest. One qualifier is that sometimes you have a patient who has a STEMI, they have chest pain, their troponin is elevated, but they don't have ST elevation. Instead, what they have is ST depression in V1 and V2. That is usually if there is a posterior STEMI. If there is a posterior STEMI, you will see ST depression in V1, V2. And that is where you need to do the V7, V8, V9 leads, which are the posterior leads. And whenever we've had those rare cases occur, you do at those posterior leads, you find that it's actually positive. You are dealing with an actual STEMI. So I'm just going to do a quick recap, and then we will be done. You determine right axis, left axis deviation by using lead 1 and AVF. And that's because the overall trajectory of electrical activation is like this, and the heart sits diagonally. If it's turned this way, that is left. If it's turned this way, that is right axis deviation. If it's left axis deviation, it means 1 will be positive and AVF will be negative. In other words, in lead 1, the QRS will mostly face up, and AVF, the QRS will mostly face down. So you look at the two on an EKG and figure out whether you're dealing with the right axis or left axis deviation. Of course, on the right axis, that means the heart turns this way, and you come to the quadrant where lead 1 is negative and AVF is positive. So AVF over here becomes positive, and lead 1 becomes negative. And that these are not geographic locations. So lead 2 can be drawn here, or it can also be drawn out here. And I'm making sure I highlight that because you will see it drawn like that in textbooks. So lead 1 can go all the way up, all the way down. Lead 2 can go all the way like that, but it will be drawn to look like that. And this is lead 3. It can be in any position. And then, of course, from the center here, you have AVR, you have AVL, and then you draw lead 3 and lead 2 and lead 3 out like that. And these two, if you have the heart in here, these two over here, they look at the high lateral wall. AVF, lead 2 and lead 3, they look at the inferior wall down here. And you have AVR over here, which looks at the left main, the most proximal vessel. If you have obstruction there, it's bad news. Or it also gives you inferences about other things, but especially about VT. V1 all the way to V6. These are geographic leads with the V1 and V2 called the septal leads. And then you have V2 all the way to V2 and V3 generally, we call them anteroseptal, but otherwise V2 all the way to V4, we call them all the way to V4, that's still really anteroseptal, and then everything else going all the way to the other end is anterolateral. These are not strict boundaries. It's just having that overall understanding about it. I hope that gives you a little bit of an introduction, remembering that in your mind you can literally separate the V's away from the rest. The V's, these are geographic locations where they are, it never changes. And on the other side now, you have the two groups, the augmented leads, and 1, 2, and 3. I know that's probably a lot, and I hope that for some of you, this is merely a revision of something that you have already encountered before. Because this video has ended up being significantly longer than I anticipated, I will stop there. Please review it. If you have any questions, let me know. We will pick up from here and apply these principles in interpreting some of the more challenging issues when it comes to EKGs. And then when it comes to other stuff like rhythm, rate, and figuring out what groups of diagnosis are likely to present with certain characteristics, once we have this foundation, it becomes easy for us to tackle those other stuff. This is Dr. Job Mogire from the House of Mastery. I will speak to you again soon.